the orthoPAC, hosted by Sam Dyer. Welcome to the orthoPAC, where we discuss up-to-date orthopedic topics for the busy clinician. I invite you to sit back and relax as I attempt to fill in the gaps between education, current events, and real-world practice.
Welcome back, listeners. Excited to be back on today. It's been a few weeks. I've been out doing other things, so I'm glad to be back on. I do have some updates for you. For those of you who are PAOS members, don't forget about our annual conference in Nashville from September the 2nd through the 6th. It's going to be a big event. I just looked at the website literally before I started recording, and we're up to almost 400 attendees, which is going to blow away last year's attendance mark for our annual meetings. The other important thing is the 31st is the last day for early bird registration, so make sure to make your room reservations, and you have to register for the conference. Doing one or the other does not ensure both. You have to do both. Okay, on with the podcast, and just wanted to provide that update right off. So today I'm going to talk a little bit about a topic I've researched. I'm giving a talk next month on basics of radiology to a primary care meeting. They asked me, and I guess they asked all of the presenters, to do some work on uninsured and underinsured access to care. And since my talk is on radiology, I thought I'd do a little research on that. And so I wanted to share some of the information I found with that with you listeners today. If you look at my history a little bit, I spent about 6 months volunteering with a local community health center 2 or 3 days a week, depending on the week, for a few hours a day, trying to, help access for underserved patients. And during that time, I realized that if you work in a community health center, or if we have any medical providers that listen to this, you not only have to be the clinician, you have to be the social worker, you have to be the counselor, you have to do it all. And it's a demanding job. So really appreciate and admire and respect those folks that are doing that work. That being said, for my time in the community health center, I found there are a lot of problems trying to get patients care. If they don't have insurance, if there are other reasons why, it's just a tough thing. So I wanted to go through some things that I found in researching for my talk, and some things for you to think about when you're trying to deliver care to folks. One of the biggest things that I read about was healthcare literacy, or the ability to understand what the provider's talking about. And that's pretty huge. Part of my health center volunteering, I also did part of something called Project Access, which the community health center could refer patients to my orthopedic group's practice, and I was the point of care for those folks, and so I could see them and refer them to orthopedic surgeons or do their treatments or whatever. And you see a lot of this that I'm going to talk about coming up in that, and patient literacy is so important. If you're in a busy orthopedic surgeon's practice and you're trying to see 60 patients in 6 hours or whatever, it's hard to spend the time and actually talk to folks and go through that. So I think that's where PAs and NPs make up a lot of the loss of that stuff. So this is important for your PAs, but it's important for docs as well. One of the studies that I read had this one thing, and we all learn this in school. When you're talking with a patient, what do you do at the end? And you recap, okay, this is what I said, this is what we did, this is what I think we should do, blah, blah, blah. And the big thing is to ask the patient, can you tell me back what we're doing? And that way you can kind of gauge if they understood what you said. And I've done this before, and you kind of get a blank stare sometimes, which means I have not done a good job at educating this patient. So think about that. Make sure your patients understand what you're telling them. Something like 54% of patients really didn't understand what was going on when they left their orthopedic clinic appointment. We can do better than that, so everybody needs to work on that. Okay, so let's talk some about the factors that affect people and why they might have trouble getting care, especially radiology services. And one thing that is certainly obvious once I read it, but something I don't think about, is patient transportation. If somebody's trying to make your appointment and they have to ride the bus and they don't have any money for a taxi or whatever, it can become a challenge. If it's raining, they got kids that got to go to school, they don't have a car. And that's happened a lot in my practice. Well, not a lot, but it happens where patients miss appointments because no rides or whatever. Well, with the underinsured and underserved, a lot of those folks don't have a different option. So consider that. I don't know how to fix that other than try to figure out, times where these folks can make it. Kind of work with them to try to figure out a time where they can schedule that meets with yours. Cultural competency, we talked about the terminology. There's a pretty prevalent mistrust of medical providers in folks that don't have as much literacy as those that are, say, more college educated or in a different socioeconomic status. There's a large medical mistrust, and I think that is a big problem. And one of the big problems, you've got to gain your patient's trust, and there are a lot of ways to do that. Communication is imperative. You have to talk in terms that your patient will understand. What I'm saying is, you can't say the same thing in the same intonation and the same verbiage to every person. You have to meet your patient where they are. And if you're talking above them or below them, your communication is going to lack. So make sure that you're meeting your patient where they are and you're discussing things that make sense to them. Instead of a muscle strain, you pulled a muscle. Instead of a fracture, I got a broken bone. I can't tell you how many times somebody told me this leader in my leg is sore. It took me a minute to figure out whether they're talking about the tendons or the ligaments. So you kind of also have to learn, for our colleagues from the north coming to the south, it's like trying to learn a different language with the accents and things. So you just kind of have to get yourself there. Now, you don't want somebody to feel like you're talking down to them. You can do this. It's the art of it. It's how you talk to folks. So I encourage everyone to think about this. Okay, if someone doesn't have insurance and they're coming through charity clinic, a lot of these folks are hard workers, working hard and manual labor jobs, and they can be embarrassed by this. So don't, you kind of have to use some common sense with this, but you don't want anybody to feel embarrassed seeking care if they can't afford it. You're there to help them. It's nice that you make money, but your primary goal is to help patients, so keep that in mind. One of the things I read about, sometimes vulnerable and low-income patients go to a safety net hospital. And this is specifically for radiology purposes, but a safety net hospital is like a community center or a community hospital or rural clinic or whatever that most likely doesn't have the highest tech or the latest and greatest technology. And so patients that would frequent those types of facilities, i.e. those in lower served, less income, that sort of thing, may not get the referrals to the high-tech imaging that they need, which is going to be more specific and accurate to diagnose disease. So something to consider, where patients are referred from. I read some studies on breast cancer and mammography, as well as lung cancer screening and CT, high-resolution CT and PET and CT scans for lung cancer. So all of these imaging modalities, there is a definite discrepancy in whether it's systemic bias, whether it is lack of understanding of terminology, whether it's missed appointments, whatever. I think we can do better than this. We can do better to improve our rates of our underserved and underinsured radiology and diagnostic imaging services. So how can we improve it other than health literacy? Well, there were several items that I read. There's been a lot of emphasis, in those of you listening to this that are in healthcare know this, on DEI, diversity, equity, and inclusion and training. Well, some of the studies that I read said that that may not be as an effective tool as reducing cost by reducing the number of images you order. Now that sounds like I'm saying don't do the education, and those of you who know me know that I'm a big advocate on DEI and a big advocate for education. That being said, if there are too many tests ordered and actual overuse of studies, and we limit the availability or the resource to other people, then those that are going to suffer the most will be the underserved and uninsured. And that is something that's really important. So I want you to think about that. I don't have time to go through all the studies with this, but I really, it's an important thing. And those of you that are listening to this, you should read about it yourselves. One of the other things that I read about was race-neutral evaluation algorithms for clinical decision making, i.e., traditionally, race has been involved in clinical decision making. Like when you look at an algorithm, say for whatever differential diagnosis, you go through different, is it yes or is it no, and if it's yes, you do this or that, if it's no, do this and that. Well, a lot of those algorithms across the medical profession include race. And that's not right. That needs to go away, in my opinion. And if we have race neutral algorithms where it eliminates bias from the provider, I think that should help improve access to folks that need it. In radiology, that is not as big of a problem from a provider standpoint because the radiologist is interpreting images, is not really seeing the patient unless it's intervention of some sort. So having more people have the screening test and having x-rays, I think that would be an important thing. So I've said a lot today, and I was doing some research and I thought it was interesting and thought-provoking, and I also wanted to put it out there for our listeners. So if you have time, it would be worthwhile to read some of this information on how you can improve access for some of the underserved and uninsured patients. Okay, that's all I've got for today. Again, I want all of our listeners who are PAOS members or who are interested in some quality orthopedic education to consider Nashville, September 2nd through the 6th. Thank you again for listening to the orthoPAC.